Welcome to the Risk Adjustment Documentation and Coding webinar series on cardiology. Today's agenda will include a brief overview of the risk adjustment model, documentation review, and cardio coding guidance. What is risk adjustment? Risk adjustment is a payment model for your Medicare Advantage population. The model utilizes a patient's demographic information and health status to predict costs for the following year. What are hierarchical condition categories, or HCCs for short? HCC is a diagnosis grouping consisting of clinically related diagnosis codes that have similarly projected costs. For example, pulmonary hypertension and cardiomyopathy fall into the same HCC category. Why is HCC risk adjustment so important? As we enter into value-based care contracts, how effectively providers document a patient's health status within the progress note will determine how much a payer will budget for the care of that patient for the following year. This is why a provider's documentation is so important, as it really paints a picture of your patient's health status. Today's focus will be on cardiology. Accurate, specific, and complete documentation by clinicians is a vital component of the risk adjustment process. This process ensures that your patient attribution receives the appropriate care and related services they require based on the severity of the condition. It really supports complexity of services provided to that patient, validates medical necessity and time spent with that patient, and really demonstrates quality of care provided to your patient. There are over 17 HCC categories for cardiology with over 1,000 diagnosis codes. This does not include chronic conditions with cardiology manifestations, such as diabetes with PVD or diabetes with circulatory complications. Disease interactions. CMS recognizes the increased burden and cost of managing members with multiple complex conditions, not accounted for in the mere adding of the disease coefficients. So while this is not an all-inclusive disease interaction chart, as you can see, congestive heart failure really has effect on multiple chronic conditions that your patient may have. CMS has also implemented alternative payment condition counts for the payment year 2021. A patient with 4 through 10 chronic conditions documented and coded on a claim will receive an additional lift due to the complexity of managing that patient with multiple chronic conditions. Documentation matters. Educating clinicians to completely and accurately document all conditions that affect managing the patient and supports accurate ICD-10 coding. Educating at the condition level versus specific initiatives will support all payment methodologies and assist with quality incentives or initiatives. Making strides to improve documentation through specificity and clarity helps identify valuable time spent with providers and help explain utilization. Clinicians are encouraged to identify conditions and document to the highest level of specificity annually. Documentation should capture a plan of care with monitoring, evaluation, assessment, and treatment for each condition. Missed codes or conditions are not factored into forecasting of medical costs and affect patient care, potentially leaving them out of disease management programs such as a congestive heart failure program or a weight loss program through the YMCA with silver sneakers. And really, while we are speaking of risk adjustment coding, accurate documentation and coding can affect all quality measures such as MIPS, MACRA, gaps in care, and really affects your ACO. Documentation for supporting codes reported. So generalized statements within a progress note are not sufficient to substantiate the assessment and plan of a diagnosis. So we have a generalized statement here. Patient has a history of diabetes, here today for refill of meds. Well, that right there really tells you that it's probably not history of diabetes. Patient was diagnosed with CHF by cardiologist and prescribed for Fariga. I'm sure I said that incorrectly. Recommend program for obesity, right? So best practice would be for a coda. Patient is a diabetic with congestive heart failure, currently on long-term insulin, morbidly obese with a BMI of 42.1, was seen by cardiologist and placed on Fariga and recommended to start an exercise program at the Y through Silver Sneakers. Really speaks to the diabetes, the congestive heart failure. I am not wondering, okay, so how obese is the patient? Most of the time we'll see obesity, and then the BMI is listed in the vitals. But we cannot assume that the patient is morbidly obese unless it's documented by the provider. So that would have been a missed opportunity. History of diabetes. Well, no, we needed to specifically say patient is a diabetic and is on long-term insulin. So this is a example of best practice. A comprehensive assessment with plan for each condition is best practice for compliant and accurate code capture. There's an additional note of when applicable. Link etiology and manifestations when defining disease processes during an encounter. Casual or linking language due to, complicated by, related to, associated with, secondary to, or caused by or with establishes the connection between the condition and a resulting manifestation or late effect. So for example, diabetes, right? The diabetes has combo codes that link the condition of a circulatory or cardiovascular condition. So if a patient has type 2 diabetes with CHN, 2 codes are required to combine those codes. So you would use E1159, which is really an unspecified code because they are not a combo code for diabetes due to HTN. And so you would use the E1159 with the I10 code to link to capture those codes and then link the conditions in the note. So again, diabetes with hypertension. More documentation and coding tips. Document relevant lab and diagnostic results in the progress note. Abnormal findings can be coded and reported during the diagnostic phase of your patient's encounter. Unspecified conditions can be documented in the note when there is not a specific diagnosis. Clear and concise documentation to state the relevance at the time of the encounter. If the condition documents as probable, likely, suspected, questionable, rule out consistent with or working diagnosis. Code the signs and symptoms, abnormal test results, or other reason for the visit. Document conditions that were previously treated and no longer exist if they have relevance to the current encounter. History codes may be utilized as secondary codes if the condition is historical or family history, has impact on the current care, or influences treatment. Document all conditions that coexist at the time of the encounter or visit and require effective patient care, treatment, or management. Chronic conditions treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for that condition. What I will say is that once a diagnosis has been established, unspecified codes should not be documented or utilized. So, with today's EMR, we like to make some important reminders. When using a pre-populated template, update the information in these sections of the note to reflect the current status of the patient on the current data service. When copying and pasting from a note of a previous visit, update any information brought forward to reflect any changes since the previous visit, and of course, update the data service as the current data service. I will say that a lot of our providers utilize Epic, and they are now a best practice alert in the EMR that really gives you a flag on HCCs. So be aware that when you're adding a code from a best practice alert, that the condition does truly exist. So, problem list should be reviewed and updated at each visit. Should indicate review was performed by the physician or the physician extender. Should only include conditions actively being treated. Problems should be removed or resolved if a more specific diagnosis code has been added to the list. For example, during my chart reviews, I will see diabetes uncomplicated. And then I will see diabetes with peripheral vascular disease. So ideally, we should move that diabetes without complications to the past medical history and treat the diabetes with peripheral vascular disease as a current condition. Resolved diagnoses should be removed to the past medical history or changed to history of if they have impact on current care or treatment. Medication list should be reviewed and reconciled at each visit. Again, should indicate review was performed by physician or physician extender. So, special note, medications that have been used for several different conditions should be linked to the condition to support the active diagnosis. For example, nitroglycerin can be prescribed for angina or heart failure or post-MI. Link the med to that specific condition to really give an accurate picture of that patient and the meds they are utilizing. And of course, provider's signature, credentials, and date that the encounter was signed are required for every encounter to be valid. I will say that there are some EMRs that allow you to bypass that step. I'm not sure if Epic does, but if it does, I would make sure that that encounter is closed with a signature and a date to ensure that when we do a chart review that they are valid for risk adjustment coding purposes. So TAMPER is an acronym that a lot of risk adjustment coders utilize to capture HCC conditions from a patient's medical record. So it really just means T, did we treat the patient? A, was the patient assessed for that condition? M, is the patient being monitored or medicated for that condition? P, is there a plan in place for that condition? E, are we evaluating with an exam or test results or a record review for that condition? Are we referring that patient to a specialist for a consult? And as a risk adjustment coder, we can use TAMPER throughout the entire patient's progress note and pull it from any part of that patient's progress note. So we're going to go over some of the cardiology documentation guidance. And since I can talk documentation and coding all day, I felt that we should maybe just touch base on some of the conditions that I see during my chart reviews, as I don't want to lose my audience or put anyone to sleep. So, congestive heart failure. Documentation and coding tips. So really specify the acuity, whether it's acute chronic or acute on chronic. Identify the type, systolic, diastolic, or combined. Identify if there's any underlying cause, such as surgery. Also code if end-stage heart failure, if applicable. Even if the patient is being seen for another condition and the heart failure affects patient care, the heart failure should be documented in coding. So one of the things that I see a lot when I do chart reviews is that the provider will document hypertension and then will document congestive heart failure and not utilize the combination codes. So what I will say, these are two codes that we can be utilized to really capture both and really speak to that patient's level of specificity, right? And health status. Hypertensive heart disease with heart failure, I 11.0, and you would add the congestive heart failure to have complete coding and documentation. And then we have I 11.9, which is hypertensive heart disease without heart failure. And you wouldn't need, of course, to add the heart failure code because they don't have heart failure. So coding guidance really states that we can assume the relationship of these two conditions, hence that when a coder is doing a chart review, when we see those two conditions, we can actually change it to the combo code for you. But ideally, I think it's important that the provider document and capture that code, because what if our chart reviewer can't really look at every record, right? So it's important that we get it right from the beginning so that we don't miss any opportunities. Acute MI, documentation and coding tips. So one of the most common errors we find with acute MI is that they are documented and coded as a present tense when the patient is being really seen for residual conditions from the stroke. And so we know that acute stroke is only coded during the initial episode of care and within that 28-day period. So after the initial acute care episode of the stroke, if the patient recovers without any late effects, sequela related to the stroke, the code would be a history code, Z86.73, personal history of TIA, cerebral infarction without residual deficits. Now, if the patient has deficits that present after the discharge from the initial acute care episode, all deficits are coded to sequela of the stroke, starting at I69.3, and the determination of the additional digits will include the late effect, code the late effect, the side of the body affected, and or dominant, non-dominant side should be documented. I will say that as a coder, if I see weakness on one side of the body documented as secondary to the stroke, then I can assume the relationship of hemiparesis or hemiplegia for that late effects of the stroke. And then weakness of one side limb documented as secondary to the stroke can be coded as monoplegia, late effects of that stroke. I will also include that there is a category of intraoperative or post-cerebral infarction starting at 197.81 and 1I97.82. I've never seen that during my chart reviews. It's probably on an inpatient basis, but I just thought I'd add that blurb in there in case it's needed. Okay, angina, documentation and coding tips. Now, this is a very tricky condition. So we know that arteriosclerotic heart disease with angina pectoris. So when we're documenting arteriosclerosis, that's a very hard word for me to say. Heart disease with angina pectoris include the following. Cause, assumed to be arteriosclerosis, of course. Document if there is any other cause. Stability, stable angina pectoris or unstable angina pectoris. Vessel, document which artery, if known, and whether the artery is native or autologous. And, of course, graft involvement. If appropriate, whether a bypass graft was involved in the angina pectoris diagnosis. Also note the original location of the graft and if it's autologous or biologic. I'm sure I said that word incorrectly. And so here are some of the diagnosis codes that capture your documentation. I-20.1, which is angina pectoris with documented spasm. I-20.8, other forms of angina pectoris. I-20.9, angina pectoris unspecified. I-25 point, arteriosclerosis of coronary arteries with angina pectoris. Providers often document patients as having ischemic heart disease with angina, receiving treatment or having stable angina, but often choose the code for ischemic heart disease without angina. And so what I will say as I do chart reviews, a patient may have had an anginal event, right? And the angina has resolved. But when I look on the med list, patient is still has an active prescription for nitroglycerin due to the angina. So this really speaks to utilization, which is one of the important factors for risk adjustment coding. So if that patient no longer has angina, we need to see that documented in the note as angina resolved, and then have that medication removed from the active medication list. Arrhythmias, documentation, and coding tips. So when documenting arrhythmias, include the following: location, atrioventricular, supraventricular; rhythm name, flutter, fibrillation; type 2 atrial flutter; long QT syndrome, sick sinus syndrome; acuity, whether it's acute or chronic; and the cause could be related to the hypokalemia, hypertension, alcohol consumption, or it could be related to medication, right? So here are some of the diagnosis codes. I-44.2, I-47 point requires additional digits. I-48 point requires additional digits for specificity. I-49.2, junctional premature depolarization. I had to look that up because I've never seen that actually on a chart review. Very interesting. And I-49.9, which is sick sinus syndrome. There are also associated conditions with cerebral vascular disease, diabetes, COPD, obstructive sleep apnea, and hyperthyroidism. So it's really important that we capture any conditions related to the arrhythmias, because it really, again, speaks to your patient's health status and really paints a picture for that payer, and the payer is going to know exactly what's wrong with that patient once we do our documentation and choose the correct codes to go out on the claim. Vascular disease, documentation and coding tips. There are approximately 300 codes that contribute to this HCC, but the most common conditions are peripheral artery disease and peripheral vascular disease that code to I-73.9. Documentation can include spasm of artery, intermittent claudication, and peripheral angiopathy not otherwise specified. Do not code arteriosclerosis of extremities here. Other vascular disease findings may be incidental, noted on diagnostic reports, should be documented if clinically significant or affects patient care, treatment, and management. So most of the time we'll find an aortic aneurysm in an imaging report, stricture of artery, arterial embolus, or aortic ectasia. Lots of times we do see those in the imaging report, and we know as providers you are reviewing that imaging report, but it's very important that you pull that finding into your progress note so that we can capture that condition, because we know that when the patient comes back in another year that you're probably going to send that patient out for more imaging just to make sure that these aneurysms are not growing and becoming a problem, for rupture for that patient. There is a combination code of diabetic peripheral artery disease and peripheral vascular disease that's utilized as a combination code. As a coder, we can assume the relationship unless the provider documents as unrelated. And this condition or this diagnosis code E11.51 is usually missed in regards to code capture. We do have diabetic with circulatory condition tools available for your practices. All you have to do is reach out to us via email, which is at the end of the presentation, and we will kindly mail out some of these tools for you if you require them. Arteriosclerosis, documentation, and coding tips. Okay, these two words really get me confused. Atherosclerosis and arteriosclerosis, right, may be used interchangeably for documentation and coding purposes. So it's very important to document the site, the laterality, symptom, or complication if applicable, especially if the patient has an ulcer related to that arteriosclerosis or atherosclerosis. And there's an additional add comment in that coding to add the severity of the ulcer from L97 through L98.49. So of course we have our atherosclerosis of the aorta, atherosclerosis of native artery of extremities, atherosclerosis of native artery of extremities with rest pain. I don't see these conditions documented a lot, especially with rest pain or atherosclerosis of renal artery, extremities with intermittent claudication. I don't know if that's to say that they're not being documented and coded accurately. I just haven't seen them during my chart reviews. So it's just some handy information to have in case, you're looking for accurate code capture, right? But we know that we need to identify these in your documentation as specific as possible. So here are some commonly missed chronic conditions that even if they're stable should be assessed and captured at least annually, or when you see that patient during your encounter, that really has impact on the treatment for that patient. So of course diabetes affects that patient on all levels of their systems, right? So if patient's diabetic and you're just as a cardiologist seeing that patient for one of their cardio conditions, it's very important to make sure that if the patient is diabetic, that you really speak to that diabetes if it's relevant to your encounter, if it's a chronic condition, and if there's a combination code for your cardiology condition with the diabetes. Alcohol use, abuse, dependence, or in remission. We know that alcohol can play an important part that patient's heart conditions. So if you have that information and it is relevant to that patient's encounter, it's important to document it in your note and choose the accurate coding, ICD-10 code. Substance abuse, equally as important, as we know that substance abuse can affect a patient's heart and really be detrimental to treatment and care of that patient. Morbid obesity with the BMI. So there's a rule that if a patient has a BMI of over 40, then they will be considered morbidly obese, right? So if that's the case, utilizing that morbidly obese documentation and adding that BMI in your encounter is very important for accurate code capture and really speaking to that patient's health status. COPD is a condition that really has detrimental effect on the patient's cardiac and cardio conditions. So it's important that if that patient does have COPD and you are aware of it, that you speak to it in your progress note and really capture that condition. And of course, chronic kidney disease. Because there is a combination code for hypertensive heart disease and chronic kidney disease, it's important that if you are aware that your patient has chronic kidney disease, that we capture that in your note. If you know the stage, perfect. Include that staging and document it in your note and capture it, the diagnosis code on your claim as well. So we're almost to the end. I hope I kept everyone awake and this was informative. But key takeaways are: review and update problem and medication lists at each visit, or at least annually. That would be important. Include problem and medication lists in your visit note to support active conditions. Document all chronic conditions at least once a year. Very important for risk coding. Document and code conditions to the highest degree of specificity. Again, we have an entire risk adjustment coding team. We're here to help you if you feel you need assistance. You can document, but you're just not sure what code we should be using. Please reach out to us because we are an extension of your practice. Document all conditions which impact your medical decision making. Assessment and plan should clearly indicate treatment plan for each condition. And also make sure that if you're picking a diagnosis code, just do a spot check on your vendor and claims going out the door to make sure that all your codes are going out the door on the claim. So we've reached the end of our presentation. As previously discussed, our email is icpcommunications@hhchealth.org. We have a team of risk coders here to help you manage your chronic conditions and with any other coding needs if required. Just reach out to us and we will gladly get back to you and maybe even schedule a chart review to make sure that your practice is doing their due diligence across the coding spectrum. Thank you and have a great day.